You want me to pull that up on the screen when you're reading, or are you
Yeah.
okay?
I think that would be helpful. Thank you.
Okay.
So, Ronnie, what is a quorum? Is it 4 out of 6?
Yes. Hi, Jennifer.
Hello. I almost said good morning. Whew. I don't know what. It's a J. Hello.
Hey, Jan. Hey,
Can't figure
Tom.
out. Sometimes it comes up a J and sometimes it comes up J Brainerd when I cut out. Weird. How are you guys?
Just got that driveway shoveled once again.
I didn't yet.
Hey, Julie.
Hello.
It's so lonely with only 13, 14 participants where we used to have 300 plus.
I know. Well, welcome, everybody, and good to see you, Melissa Sager.
Good to see you guys too. Tuning in for my last Board of Health meeting.
Oh,
So sad.
Sad.
Why is this not coming out? Okay.
okay. Ronnie, it's 4 o'clock, so I'm going to call this meeting to order. I know that Julie Mullica will be joining us a little bit late, and hopefully Rosanna will be joining us soon, but we do have a quorum and we have so much to cover. I'll just mention that Julie had a conflict with a school play that she had to attend. And so I'm filling in for her, but she will be joining us and she'll be chairing next month's meeting. So just let you know. And shall we begin with the roll call, Ronnie?
Sure. Please state present after your name is called. Representing Adams County on the Board of Health. I know Julie Mullica is not here yet. She'll be joining. Rosanna Reyes. Julie Shills.
Present.
Representing Arapahoe County on the Board of Health, Jan Brainerd.
Present.
Dr. Thomas Faywell.
Present.
Dr. Kaya Gallagher.
Present.
Tri-County Health Department Leadership, Adam Anderson, Interim Director of Planning and Information Management.
Present.
Michelle Askenazi, Director of Emergency Preparedness, Response, and Communicable Disease Surveillance.
Present.
Heather Baumgartner, Director of Community Health Promotion.
Present.
Lisa Bolstad, Administrative Assistant.
Present.
Jill Bonchinsky, Director of Nutrition.
Present.
And I'm Ronnie Brockman, Executive Assistant. Monique Didier, Director of Administration and Finance.
Present.
Dr. John Douglas, Executive Director. And, oh, here he comes. Mame Furman, Director of Human Resources.
Present.
Randy, Director of Nursing.
Present.
Brian Halavasek, Director of Environmental Health.
Present.
Jennifer Ludwig, Deputy Director.
Present.
And Dr. John Douglas, Executive Director.
Present.
Roll call is now complete.
Thank you. Did the Tri-County team want to introduce anyone who's attending our meeting tonight?
I can real quickly. This is Brian. I'm not sure if Kate is on yet, but I know Sheila is. So, oh, there's Kate joining. So Kate Fury, our air quality policy and program specialist, will be presenting along with Sheila Lynch, our land use and built environment manager around some of our air quality efforts. So they're just hopping on. I just want to introduce them.
Great, thank you. Anybody else?
Sure, I'll just introduce again Alex Kellogg. She's our COVID Partnerships and Strategies Program Manager, and I knew you met her before, but just wanted to introduce her. She just jumped on, and we'll be here through the COVID update.
Great, thank you.
Alex, do you have anybody to introduce? No, okay.
Unfortunately, we weren't able to swing it.
Yeah, I sent the board members a really wonderful short video of some of our vaccine champions. And I thought if you saw it, you'd like to meet them. So we invited a couple to join us, but they were too busy working in the community. So they couldn't make it on short notice. Sorry.
Great. Well, it was a great video. Really enjoyed it. Thank you for sharing that. The next item on the agenda is a proclamation of appreciation to staff in commemoration of efforts to fight the COVID-19 pandemic. Rane, did you want to pull that up on the screen, please? This is somewhat lengthy, but I think we're at a momentous time, celebrating or at least remembering 2 years from the time when the first 2 cases of COVID-19 were identified in Colorado, which led to the activation of an emergency response to the COVID-19 pandemic by Tri-County, shifting the attention of much of the agency to a single priority, increasing the impacts of this illness on our community, lessening the impacts of this illness on our communities, and resulting in massive disruptions in all aspects of our community life. So whereas over the last 2 years, we have experienced a tragically heavy loss of life, including almost 3,000 deaths across our 3 counties, over 12,000 across Colorado, and almost 950,000 across our nation. And whereas public health agencies like Tri-County were dramatically impacted by the unprecedented magnitude of the many demands placed on us, the continuously evolving understanding of how to fight the pandemic, and particularly by the unprecedented divisiveness and the profound loss of trust in the advice of experts that the pandemic spawned. And whereas we have all experienced a collective trauma from this pandemic, with many losing loved ones, jobs, and financial security, missing out on education, postponing important celebrations, and losing time with those we love. And whereas over the course of viral surges and changes to guidance and requirements, we all have been forced out of our comfort zones and asked time and time again to adopt new and innovative ways of working and living, while all the while continuing to provide essential public health services. And whereas residents across our communities are worn out, fatigued, frustrated, and physically exhausted, especially public health workers who have been on the front lines since the earliest days of this pandemic. And whereas public health professionals here at Tri-County, across the state of Colorado and across the country, have rapidly applied the many lessons learned and new skills and knowledge acquired to respond to the pandemic. And whereas even as we move into what will hopefully remain a steady trajectory of improvement, we grow more amazed each day as to the enormous contributions and sacrifices by Tri-County staff, who have all been a part of an event of immense historic importance, and whose experiences together should be a source of great pride to them and their communities for decades to come. Now, therefore, be it proclaimed, the Tri-County Health Department Board of Health, with deep appreciation, commends the heroic efforts of Tri-County staff over the past 2 years. The challenges of this pandemic and those still ahead of us generate a multitude of mixed emotions, and above all, gratitude for the countless hours, incredible effort, and sheer fortitude shown by all the people who make up Tri-County. So therefore, on this 10th day of March, Board of Health issues this proclamation. If we were all in a room together, we could stand up and applaud, but we'll just have to do this virtually on behalf of the Board of Health. Thank you, thank you, thank you. Okay. Moving on to the next item on the agenda, we have several action items. As the first action item, do I have a motion to approve the minutes from February 10th?
So moved.
Is there a second?
Second.
All in favor, oh, sorry, any discussion? Not hearing any, all in favor, please say aye.
Aye.
Anyone opposed? Motion carries. The second motion is to approve the financial statements from November 20th, 2021. Is there a motion to approve?
So moved.
Is there a second?
Second.
Any discussion? All in favor? Say aye.
Aye.
Aye. Anyone opposed? Motion carries. And as a third action item, the board needs to approve the most recent changes to our bylaws. As you can see from the track changes that were in your packet, these updates are just editorial changes to reflect the leadership changes that we approved in December. So is there a motion to approve the bylaw amendments? I will move. Is there a second? Julie, did you want a second?
Sure. Second.
Is there any discussion or questions about this? Not
Well, I
seeing
was
it.
against it to begin with. I'm against it now.
I'm sorry. Could you repeat that, Tom?
Yeah, I was against it when it was proposed. I'm against it now.
Okay. Point taken. Any other comments or questions? Then could all those in favor say aye?
Aye.
Anyone opposed?
Nay.
Okay, so that would be 4 out of 6. Renee, just for the record.
Quick question too. Who was the one who initially made that motion?
I think I did.
You did. Okay, thank you.
Okay. Moving on to the information items. Tonight, the Board of Health will receive an update on Tri-County efforts related to improving air quality. So Brian, did you want to introduce our panelists, please? I know that you told us who's on your team, but let us hear who's going to be speaking.
Yeah, thanks, Kaya. And maybe while Kate's pulling that up and sharing just real quickly, I think, from last year, we provided a few informational updates and some written updates in the executive director report. And we felt it was good timing again to come back and share some updates and the really good work we're doing related to, some of the efforts around Suncor and some of the legislative impacts, and then spend a little time just sort of in a brief overview around some of the work we've been doing in our Love My Air program that we've been going on for a couple of years. And so we thought the timing was good. And hopefully you've had a chance to take a look at the slides, and then Kate, I guess if you're able to pull those up and take it away, that would be wonderful.
All right, so you should be seeing the slides right now.
Yep. Thanks.
All right, so we're going to go over the status of the air quality permit for Suncor's Plant 2 Title V permit. Then we're going to touch briefly on some of the monitoring efforts that are going on in Commerce City. And then Sheila's going to provide a brief overview of the Love My Air program. So a Title V permit is different than a regular air permit, and it has to do with the size of the facility and whether or not it's a major or minor source as defined by Regulation 3. So I mean, the thing to know is that Suncor goes through a special process that other facilities don't have to go through, other like regular smaller facilities. And when they do permit modifications, unless it's a major modification, that modification it's not subject to public comment, but rather all of those modifications are aggregated together and then submitted along with their Title V process. They actually have 2 separate Title V permits. They have one for plants 1 and 3 and one for plant 2. And that's because historically they were 2 separately owned facilities. Then Suncor purchased them and combined them into one facility. So the initial permit was issued in 2006, and then they submitted their renewal application in 2010. It took the division a while to approve the permit, and I can't really speak to that. I don't work at the division. I don't know what happened behind the scenes, but in the intervening years, so the regulations do allow the facility to continue to operate as long as the renewal permit has been submitted, and it was. So in the intervening time, they filed approximately 40 permit modifications. Now, this is for things like we took a boiler out and put a new boiler in, or we installed a new piece of equipment, or, we changed, it might be administrative, that this personnel has changed, or this is the new contact number. So not all of them are for equipment changes. The initial public comment period was in February of 2021, so last year. That initial comment period ran for 30 days. However, it was extended by the Air Quality Control Commission, or the AQCC, and they also held 2 public comment listening sessions and accepted written comment as well. So members of the public and other interested parties were able to speak in front of the Air Quality Control Commission about the Suncor permit. Earlier this year in February, the Air Pollution Control Division issued the approval of the permit with some minor revisions, and then they sent the permit to the EPA for the EPA's approval, and they released their written responses to the public comments that were made both to the Air Pollution Control Division and the Air Quality Control Commission. So in terms of next steps, there's a 60-day limited public comment period that will begin once the EPA review period ends with either the approval or denial. I would be extremely surprised if they deny this permit. It's most likely that they will approve it. And when I say a limited public comment period, what that means is that you can only comment on things that were already brought up. So no new issues can be raised during this time period. And then that public comment period will end in May. So Tri-County did submit public comments, written comments, and oral comments. We submitted written comments to both the Air Pollution Control Division and the Air Quality Control Commission. And we also submitted oral comments to the Air Quality Control Commission. And the comments that we made to the Air Pollution Control Division, we recommended that CDPHE use its own environmental justice policies to justify extra control measures on the facility. We requested that they perform additional studies and facility-wide modeling. And we identified the need for Suncor to include a schedule of compliance in the permit. It's kind of a technical argument that has to do with some of the regulations in Reg 3. And we also made some other technical changes. I'm happy to go into those further, but for the purpose of this presentation, I wanted to keep it kind of high level. And then when we submitted comments to the Air Quality Control Commission, we tried to go a little bit beyond what we thought was in the power of the division to do and look at more of a process-oriented approach and maybe make suggestions on ways that the additional rulemakings could be sought, and such as improving the current Title V permit approval and renewal process to improve the timeliness and amount of public input. We also requested that they pursue a refinery-specific rulemaking that would more directly address health equity and environmental justice and address a broader list of air contaminants. Now, that was partially addressed last year in House Bill 21-1189, which I'm going to talk about a little bit on the next slide, and may be addressed by the current air toxics legislation that is in front of the legislation right now. In addition to submitting our own public comments, we worked closely with Adams County, the City and County of Denver, specifically DDPHE, and Commerce City months before the permit was submitted to try to get on the same page and a kind of like a divide and conquer approach to spread capacity out amongst all our agencies and come up with a fairly unified front. After the comments were submitted, we met with CDPHE multiple times, multiple different units, starting at the permit unit and kind of working our way up to see if we could move this further. We've also met with various environmental groups. So some of these environmental groups, particularly Earth Justice, have invested a large amount of time and resources. They conducted their own modeling assessments. Their comments were hundreds of pages long to see kind of what next steps they thought were best. So kind of getting away from the Suncor permit and moving on to kind of the air monitoring efforts that are currently ongoing in Commerce City. So I think when I spoke to you last, we talked about the SEP, the Supplemental Environmental Projects Grants that were issued as part of the March 2020 Order of Consent Decree. settlement with the state that Suncor provided. So $1.8 million was awarded to Cultivando to conduct a series of education, modeling, and air monitoring efforts and studies around the Commerce City, North Denver area. And so Cultivando has partnered with Boulder Air to install regulatory grade monitors and distribute purple air sensors to community members. And that data is available at the link listed in the slide if you want to look at that. Now, that program is only guaranteed funding for the length of the step, which I believe is 1 year. And I believe it's 1 year from when the monitors were installed, which was the third quarter of 2021, unless they receive additional funding. Suncor also has implemented a voluntary community air monitoring network in North Denver, Commerce City area. And that includes a mixture of regulatory grade monitors and non-regulatory sensors. They also provide that data on a website that's listed there. Now, they're not required to do that program, and it's only been guaranteed funding for a year as well. Now, pursuant to the air toxics bill from last year, 1189, they are required to install a fence line monitoring system around their facility to monitor for hydrogen cyanide, hydrogen sulfide, and benzene. And they have submitted that plan to the air quality or the air pollution control division. And we've looked at that plan and we've been meeting with the APCD to discuss that plan further. In addition, the APCD has been holding public hearings, which I've attended the first one, I'll attend the second one as well. And that needs to be in place, their air monitoring network, the fence line air monitoring plan by January of 2023. In addition, House Bill 21-1189 required a community air monitoring program be installed by APCD, but they have until next year to come up with a plan for that. They haven't expressed what that plan will be. In addition, they have a CAML, which is their Colorado Air Monitoring Mobile Lab that they can pull out there whenever they want, do studies. And they also have a mobile air monitoring van that can track emissions in real time while it's in motion, which is slightly different than what the CAML does because the CAML needs to be set up in a location and left alone. And then the data is collected and brought back and analyzed instead of the mobile van that can take real-time measurements as it drives. And they deploy these to do special studies to detect leaks or after incidents. So that can be deployed as needed around Suncor. And with that, I'm gonna go ahead and send it over to Sheila.
Yeah, and I wonder, first, Kate, thank you. That was a fantastic overview. And I wonder, maybe because the next slide is going to jump into a different topic, do we want to take a few questions now? Would that make sense?
Yeah, I think that's a great idea. And actually, Kate, thank you for that very thorough and concise overview. I guess I just wanted to ask you, since it appears that the Suncor permit is now being reviewed by EPA or has moved forward, were all of the comments that were compiled from these various different organizations part of that permit? I mean, do you feel that the Suncor permit application now reflects all of the concerns and considerations that were brought up?
So no, it doesn't. They did make some revisions. So, and it's hard to really talk about because a lot of the things that people are asking for are very technical in nature. They have to do with the way that the division allows Suncor to calculate their emissions, whether or not they consider some of these modifications to be major modifications or minor modifications. That has to do, it gets very technical. But in general, what the division did, the revision that the division did do was to require an annual actual emissions report. So currently the way that it works is every quarter, Suncor has to report how long of an exceedance and what kind of compound and what was exceeded, but it's only the length of time and the compound and like the particular part of the refinery that was in excess emissions. And that doesn't really do much, right? Because you have no idea how much was actually emitted. So the idea is by switching to or including an additional annual emissions, you'll actually know the amount of concentration that was released. It's to be determined if that's going to be as effective as we would like it to be.
So if in fact not all of the concerns were reflected, but you do still feel that EPA will approve the permit?
Yeah, I don't see a reason why they wouldn't. I mean, the thing is that in the defense of the division, they're somewhat restricted, right? Because they can only make changes up to what they believe is their authority in the regulations. And the way that it is right now in Colorado, we have adopted pretty much wholesale what the federal regs are without any additional modifications. I do think that there is a need at the legislative level, perhaps, probably to request additional regulations and to make it, Colorado specific. I don't know what the appetite for that is, or whether or not that's something that the environmental groups will choose to pursue.
Yeah, I was just going to add, Kate, and thanks for explaining that. There's probably a lot of comments that were submitted by a lot of organizations that maybe, like Kate's saying, above and beyond what the Air Pollution Control Division can, I guess, legally require in a permit. But I think that's why the Air Quality Control Commission, we made a lot of comments there about sort of the bigger picture, maybe systematic ways that, that a lot of this permitting can happen. And so I think that's probably the best place to try to make some of those bigger, broader changes. Would you say that's accurate, Kate?
Yes, and I would also say with the upcoming reclassification of our ozone non-attainment status from serious to severe, that's going to make a lot of sources that are currently minor sources are going to become major sources. So there's a request in front of the legislature for an increased funding to the Air Pollution Control Division, which will allow them to hire a large number of permit staff, and will give really the division a chance to change the culture that they have and kind of like wholesale change the entire division. So I think that's a possibility coming down the track as well.
Thank you. Are there any other questions? All right, not seeing any. Sheila?
Sure, thank you. Thanks again, Kate. That was a wonderful overview. And I just want to thank you all for allowing us to share about this meaningful work in air quality. And I'm going to transition to talk a little bit about our Love My Air program. We wanted to provide a short overview this evening of this really wonderful program, as it's truly taking off in Arapahoe and Adams counties. And tonight is just a sneak preview, because we plan to come back in a couple months and to provide a really more robust report on more comprehensively all the different pieces of this program. But a little bit of background on this program. About 2.5 years ago, we had the opportunity to pitch this idea to CDPHE's Environmental Health Tracking Program to essentially do two things. First, connect community partners to real-time data related to air quality, specifically to measure particulate matter in their immediate area, and then to support community partners in their efforts to incorporate this data into programming, public engagement, and policy development, with, of course, the intent of mitigating the impacts of poor air quality in their communities. And so we launched late 2019 and had plans for a big, robust group. And of course, as you all know, things changed in early 2020. And so we were able to continue and to persevere in 2020 with 2 partners. We had in this initial stage $45,000 of funding to do that. We had such success in that first year of really engaging these 2 partners deeply that CDPHE actually returned to us and said, we'd like to expand your funding. We'd like to extend it another year, and we'd like to double it for this second year. So in the second year, we received approximately $84,000, and that year comes to an end at the end of March. And so what we did is in that first year, I said there were 2 partners. We expanded to up to 6 partners over the last year. And we really looked at what things were working well. And one of the things we heard from partners was the learning community that we had started to foster. So we launched officially what we call our Love My Air learning cohort. And so all partners engage on a regular basis. We meet monthly, and then we're connected in a lot of different ways throughout the month, sharing our learnings, sharing information, providing alerts about different air quality issues that they can incorporate into their work. And I want to note that I see on the screen that we have 7 partners. So we had 6, we've now added 2 more. So we actually are up to 8 partners. Kate installed air sensors just a few weeks ago in the city of Sheridan and also in the city of Englewood. So we have expanded even more greatly in Arapahoe County. And so we have a total of 17 sensors deployed, I believe, and we have 3 more to deploy. We hope to do that in the next month or so. The other thing I just wanted to mention is that, and this is why we want to come back to you in a couple months, is we're actively working with partners on our sustainability plan. So I mentioned that the funding ends on March, at the end of March. However, we've been able to fund the air sensors through the end of 2022. And our support in our partnership development that our team member, Anne-Marie Heinrich, and our former team member, Peng Moa, are deeply engaged in, that is really supported through our work on the land use and built environment team. And so we can continue to do that through the end of the year, and all of our partners will have funding for their air sensors through the end of the year. So from now until the end of the year, we're working hard to figure out how do we move this forward. And one of the models that we're using is we are deeply engaged with this learning cohort to get their input into what are the best sustainability models. So we're co-creating grant proposals as we speak with our learning cohort to figure out how we can continue to support this great work and support all the incredible work that's happening with all of our partners. So that's just a sneak preview tonight. I was going to put in the chat, we have it on the slide, the website or the dashboard that hosts some of the data. So you can take a look at that, and we look forward to return in a couple months and hopefully share more about our sustainability plans. And happy to take any questions if anybody has them.
Thank you, Sheila. How exciting. Did you say that the funding ends in March? Did I hear that correctly?
Yeah, so our funding officially ends in March. We were able to use the funding to pay for the air sensor leases through the end of the year. So we will continue the cohort through the end of the year because they all have access to their data, and we have staff to continue to convene that cohort. But after the end of December, we'll have to figure out how to keep that going. With that said, we have already heard from multiple partners that their organizations are so impressed with this program that they're willing to invest in their own, paying for their own licenses to keep those air quality sensors at their facilities.
That's great news. Did anyone have any questions for Sheila? No?
Yeah, that was really great, both Kate and Sheila. Thanks so much. Sheila, I know when we started this, there was some interaction with Denver around posting of similar monitors. And I wonder if you could, update us, all of us, where does that collaboration stand? Because that seemed like an early, rich part of the effort.
Yes. I know I had a hard time figuring out how much to share in my 3 minutes, but yes, Denver launched a program maybe about 5 years ago now called Denver Love My Air. And so we were really actually lucky to learn from them. And their model is to provide air sensors and work with school districts, since the city and county of Denver primarily has one public school district in their county. And we started out on that path. And then COVID hit, and most of our school districts said, we won't even be in our buildings, so we can't really engage in this. So we actually did some kind of regrouping, spoke to a lot of different partners, and internally really thought deeply about how do we translate this wonderful program into something that fits our counties. And so our partners span libraries, local governments, and we do have one school district that's working with us. And then as far as future collaboration, we continue to work with Denver to build a more regional network of this data. And that's something when we come back again, we can talk more deeply about those regional collaborations. But our hope is that we can start kind of centralizing where people can get data around air quality to make it a little bit more user-friendly. As far as our dashboard and all of the different models we're using, we're really leaning on the learnings from Denver, and they've been an incredible partner because they've shared so much with us. And so we look forward to we can dive deeper into that when we come back.
Great. Thank you.
Thank you, Sheila. We'll look forward to hearing more from you, and welcome, Rosanna. Not seeing any.
Rosanna's got her hand
Did you
up.
have your hands up?
Which school district is that, Sheila, in Adams County?
We are working with Adams 12.
5-star. Great.
Mm-hmm.
My alma mater.
Great, not seeing any more hands up. Let's move to the next information topic, which is an update on mental health from Adam Anderson. So Adam.
Great. Let me just share my screen. All right. So I'm gonna make this full screen. Yeah. All right. Everybody can see that then? Yep. Okay. All right, so this is something prior to COVID, we talked about a lot. And for those of you who may have attended the mental health summit that was put on by some of our community health promotion folks, this will be a repeat of that. But so we've been talking prior to COVID and even during COVID about due to issues around COVID, we've been talking about mental health, and probably we haven't had as much time to really dive into the data as we had prior to COVID. But this is just going to be a quick update on a lot of those common indicators that we've looked at in the past. And so this is going to focus on mental health status of adults and youth for Adams and Arapahoe County, looking at trends in suicide mortality, and then circumstances around those deaths. So when we look at BRFSS data, which is sort of the benchmark at this point for poor mental health status over time, we can see that both for Adams, Arapahoe, and for Colorado, we see a trending up even prior to 2016, but from 2016 forward, definitely just a kind of a slow incremental increase from single digit or single percentages to getting up into that sort of 12% range. Some of the takeaways to this, though, so if we look at, if we split this up by demographics, we can see that individuals making less than $25,000 a year had over twice the rate of poor mental health as compared to those making more than that. And this applies for both Adams and Arapahoe County in 2020. Those reporting, identifying as LGBTQ reported poor mental health at 2 to 4 times the rate of their heterosexual or straight counterparts, and we're looking at approximately 14% compared to roughly 60%. Specific to Adams County, Black individuals or individuals reporting, identifying as Black reported much higher rates at around 28%, while Hispanics actually reported lower rates of poor mental health at around 6%. For Arapahoe County, those that were reporting for race other non-Hispanic or American Indian Alaska Native were the ones reporting higher rates within Arapahoe County. So this has been a question continually, I think, during COVID due to issues just around social isolation and then issues around schools and masking. But the Colorado Health Institute, as part of their Colorado Health Access Survey, were asking, within their survey, asking if you have experienced a decline in mental health, such as anxiety, depression, and loneliness, as a result of COVID-19. This is for individuals ages 5 and older, and we can see here that we're looking at, so for the 7-county metro area, we're looking at roughly 35% of individuals reporting that they've experienced any of these mental health issues, with Denver reporting the highest at almost 50%. And then another question that the Colorado Health Institute continually asks is around actually getting care, like if if you are reporting poor mental health issues and you're looking for care, how many of those individuals were not able to receive care who wanted care? And across the 7-county metro area, it hovers between the 10 to 15% range of individuals not being able to receive care who need care. And so if we look specifically at just Adams and Arapahoe County, this slide just crops out those two Colorado Health Institute indicators specific to Adams and Arapahoe County.
Excuse me, Adam, we're
Yeah.
having a little trouble. You're fading in and out. I'm not sure what is going on. Perhaps you need to get closer to your microphone.
Sorry, I actually probably should get a microphone. I feel like there's something, I get that from my laptop, but I'll try and speak louder just directly into the laptop. Thanks for letting me know. Okay, so that if we focus specifically on youth, we can look at the Healthy Kids Colorado survey, and 2019 might seem like ages ago nowadays, and especially with how quickly we get COVID data, but this is the most recent Healthy Kids Colorado survey data set. The next one would be 2021, which should be coming out soon. I believe all of you have seen this cascade of mental health indicators from Healthy Kids Colorado. So over here on the left-hand side, it's the percent of students who felt sad or hopeless, where they stopped doing usual activities in the past 12 months, all the way to the right-hand side, which is the sort of extreme scenario of the percent of students who have attempted suicide one or more times in the past 12 months. So over here on the left-hand side, we can see that for Adams and Arapahoe and for the state as a whole, we have roughly a third of students who, within the past 12 months, who have felt sad or hopeless to the point of stopping doing normal activities. Next is those who have considered suicide in the past year, so around 16-17%. The next one is, those are students who have made a plan about how they would attempt suicide at around 12%, and then roughly 7 to 8% of students have actually attempted suicide. And so this is based on 2019 estimates. If we look at the trend in that over time, so sorry, this gets a little busy, but we have Adams County indicators on the far left side, Arapahoe in the middle, Douglas County on the right-hand side. And to me, there's not any sort of obvious trends, maybe with the exception of Arapahoe County trending up with individuals who report feeling sad or hopelessness, where they've stopped their activities, trending up from 26% to 33% of students. A lot of these seem to just sort of be bouncing around a little bit. Obviously, all of these are too high, but that would be the main trend that you could pull out from this graph. And sorry, there's a lot of slides in here. A lot of them I put in here just for your reference too, just in case you wanted to go back to take a look at them. But if we want to just identify the sort of the low-hanging fruit out of, so if we stratify those indicators and we look at who's disproportionately affected or who's disproportionately reporting these indicators, across Adams County, Arapahoe County, and Colorado, it falls heavily on those students identifying as LGBTQ. So this is that first indicator, the percent of students who felt sad or hopeless, who've stopped doing their normal activities within the past 12 months, and roughly 2/3 of those who identify as bisexual are reporting that, and half of those who are reporting identifying as gay or lesbian. And then, I mean, even the their heterosexual counterparts are at almost a third though too. So these are just, they're just high across the board but definitely you can see that over here in the first two columns, it's a heavy burden on those individuals. When we look at the percent of students who have attempted suicide within the past 12 months, this breaks out even more extreme in terms of those that are identifying as bisexual, gay, or lesbian compared to their heterosexual counterparts, as far as anywhere from a third to 18% have attempted suicide in the past 12 months compared to these around 5% for the heterosexual counterparts. For those of you who attended the mental health summit on earlier this week, we did have some race ethnicity breakdowns, and there were some questions about that. And if we have time, I can talk about why there is some suppressed data later. But a lot of it has to do with sampling size and the way that the survey is conducted. In addition to some of the Adams County has their own youth survey that I want to say sort of competes for those students. Okay, so next, if we look specifically at suicide mortality, we can see that it bounces around a little bit. The Colorado number, that gray line, smoothed out a little bit just because we're looking at the entire state. But I think we can definitively see a trend going back to 2010 of an increase in suicide mortality rates in the past 10 years, and across Adams County, Arapahoe County, and Colorado as a whole. If we look at that by age group, both counties have an increase in the 0 to 14 population, so our younger age group, and our 65 and over age group. Not that anybody, just personally, it's a little concerning that those are the age groups increasing. But I think that there's definitely different factors there that would play into that, but I think that's probably for our program folks to really dive into. But there's definitely some age groups that are disproportionately affected by this increase. The next two slides are basically just to provide some demographic stratifications for individuals who have died by suicide in the past year. And so I have this for both Adams and Arapahoe County, but you could dig into it more. But just for key takeaways, it's disproportionately males, single, and again, we have even though the rates for those younger groups and older groups are higher and increasing, the numbers you can see what the actual numbers are here. So sometimes the crude numbers or the actual counts can help to also provide some context here. So we have the same thing for Arapahoe, and the trend is very similar in Arapahoe as it is for Adams. And then the next three slides are density surfaces of where individuals resided who have died by suicide. So this is 14 through 15, here's 16 through 17, and 18 through 20. 18 through 19. And you can see some slight shifts in where those hot spots, if you want to call it that, show up. But also note that on the side there, you can get the total counts as well by county that represent the surface that you're looking at. So finally, the last thing that I want to touch on are the circumstances around suicide, because this tends to be sometimes the most actionable data. So this is for from the NVDRS, the National Violent Death Reporting System. It's a program run out of the Vital Records Office at CPHE. And they look at the circumstances around suicide. So this one's for Adams County. The next slide is for Arapahoe County. Again, there's some similar trends in here, but these, and sorry, these are a bit abbreviated, but the top 4 rows up there represent some sort of mental health diagnoses or depression. And you can see that 50 to 60% of individuals who've died by suicide have reported some sort of something along those lines of a mental health diagnosis or reporting depression. 30 to 40% report issues with alcohol or substances. So you can see in there, so the middle one, the middle one, we have alcohol at 42%, and then substances down here at 36%. So those individuals who, so roughly a third to half have some sort of substance use issue. And then a quarter of them are reporting some sort of job or financial issue within the past few weeks prior to suicide. And so if we look at Arapahoe County, again, the trend is somewhat similar with that 50 to 60% reporting a mental health diagnosis or issue. Slightly lower in terms of alcohol and substances at around 30%. And then even a little bit lower for that job or financial category at around 15%. For youth who died by suicide, again, we have similar trends in both counties, but 75% have, so this top bar up here is your child or youth ever communicated with you about mental health issues. And so most parents have reported that their kids prior to dying by suicide have reported these types of issues. They've talked about their mental health. They've talked about actually hurting themselves at around 40%. And then about a third of them have reported some sort of maltreatment. And then over here on the right-hand side, these life stressors, about 35% of them had something in the category of family issues. When we look at bullying, which is kind of a common thing that people want to pull out too, within Adams County, about 25% of them have experienced, have been a victim of bullying. And so then when we look at Arapahoe County, again, we have similar trends there around family issues at around 50%. So that means like family discord, arguments with parents, divorce or separation of parents. And then bullying around 20%. And then this issue of the child communicating issues with their parents, again, between 60 and 75%, where that's been brought up by the individual or by the child. And then the maltreatment, the percent with the maltreatment is just under 40%. Hopefully I didn't go too far over, but I will leave it there. And if you have any questions, I'm happy to answer them.
Oh, thanks, Adam. Heather anticipated the question I was going to ask, which is, given the sobering statistics, what are the programmatic responses? And I guess we're going to be hearing about that next month. So so thank you for that very detailed and very important presentation. Dr. Faywell, you had a question?
Not so much a question as a comment that has nothing to do with you, Adam. But for those of us who answer that we have not felt any mental health issues or depression, after listening to your presentation, we might change our answer. It's very sobering.
Thank you. Yes, indeed. Any other questions, comments? We really appreciate all of that terrific information. So thank you so much for pulling it together.
Of course. Thanks.
Okay, so we'll move on to the next information item. Dr. Douglas, can you give us an update on where things stand relative to COVID-19?
Sure, very happy to do so. Thank you, Lisa, for getting these pulled up. Dr. Faywell, I guess one of our interventions is going to be not giving people talks about this. We'll have to ask Heather's team to consider that. And I do want to thank those of you who attended the mental health summit that Heather's team put together. This was, as you know, intended to be a collaborative planning process, and we really appreciated the input from many, many community members. And Heather, I'm hoping we're going to hear, that's part of what we'll hear by next month. So great presentations. I hope the board appreciates that as COVID begins to diminish and stay low, we're going to have a lot more opportunity to present more information on other topics. I know our team is chafing at the bit to share a lot of that good information with you. So next slide, please, Lisa. I'm going to quickly go through our trends on, from case hospitalization data, update on where we stand with vaccination. I don't know if Alex is still here, great. And Alex has been doing fantastic work since she joined the team. Talk a little bit about some of the emerging roadmaps and plans that are happening, as well as sort of some reflections looking forward, as I've done on each of the past 7 or 8 different COVID overviews. Next slide, please. So, you know, if we had 2 minutes, the message would be it's all getting better, but we can't shoot off fireworks yet. So case rates have been falling across the country. This very, very busy graph, just focus on the red circles, gives you a sense of where Colorado stands in terms of state ranking. We're number 20 in cases and number 41 in terms of hospitalizations. We've actually seen this sort of different ranking for the last 6 months or so. And I think at least part of what's going on is that even now, even though testing has diminished somewhat as cases and needs for testing have dropped off, Colorado probably still tests relatively more than some of our companion states. Our test positivity data has typically been lower than some of our companion states, but the rankings aren't really the story here. Next slide, please, Lisa. The rankings are, as we talked about last month, the really unprecedented behavior of COVID over the last 6 weeks or so. We're now both in our 3 counties as well as across the state at the lowest level of case rates since June of 20. That's not 21, that's June of 20. So we are getting to levels that I'd have to tell you that 6 months ago and certainly 2 months ago, I did not think we'd be here. And I think what's gone on is a combination of what we talked about the last Board of Health meeting, natural infection on top of a pretty high rate of vaccine immunity, with the estimated rate of persons being immune from either a vaccine or natural infection being now 90-some odd percent. So, and as you can see on the right graph, the state rates are almost exactly mirroring, even to the little peaks and valleys, what's happening across our 3 counties. Maybe not a surprise, since our 3 counties are about 26% of the state's total. Next slide, please. This is sort of a visual of sequential maps that the state still puts up and updates on a 5-day-a-week basis about cumulative incidence rates on their, what used to be their dial dashboard. We don't have the dial anymore, but we still show these rates. And I've crammed 4 maps together here from early January, the peak of Omicron on the 10th, early February, our last Board of Health meeting, and then the Board of Health meeting today, a couple of days ago. And you know, if you just squint and you can see the color cascade, it really tells the story, going from, you know, maybe 30% red in early January to the whole state more or less being red on the peak of Omicron. To a month ago, we began to see the clouds parting, more orange and red. And now, I just would not have believed that we would have been at rates this low, with the vast majority of the state being green, which is less than or equal to 35 cases per 100,000, per 7-day period, and almost all of the rest of the state being blue. So it has been just nothing short of, I wouldn't say miraculous, because we think we've got a pretty good explanation for what happened, but certainly, again, dramatic and unprecedented. Next slide, please. One caveat to this general good news. These are graphs, the state on the left updates on a weekly basis, and a modeling team working with the state updates periodically on the right. On the left shows you the variance over time. Colorado experienced the first of the Alpha variant from the UK, that was blue. Then Delta came in the summer, that's lavender. And then it sort of got pushed out by Omicron, that's turquoise. The rightmost graph shows you the breakdown of what is really now almost 100% one of the subfamily of Omicron, BA1, BA1.1, and BA2. And as we talked about last time, BA1.1 was always the major story in Colorado. As far as we can tell, it behaves almost exactly the same as BA1. What's interesting, and I want to point it out to you, and I don't know that it is going to do anything, but we have to keep our eye on it, is BA2. Now, BA2 is now, of the total that's Omicron, about 2%. It's pretty small. But BA2 is what changed trajectories in Europe, Denmark a month ago, and now it appears Germany's about 50% BA2. Germany yesterday experienced the highest number of reported cases they'd had since the beginning of the pandemic. Now, BA2, like BA1.1 and like BA1, actually appears to be behaving pretty similarly in terms of symptomatology. It's milder. As far as we can tell, it is covered by either prior immunity or prior vaccination. So if that supposition, which is not slam dunk confirmed, but it seems pretty likely, holds true, I don't think BA2 is likely to be an issue. But I do think these variants of concern are the kind of things that, as we get into these very, very promising springtime and summertime better days for COVID, are the kind of things we'll have to be watching. Next slide, please. So those are cases. The CDC, as I think you're probably aware, did a fairly major transition about 10 days ago, where they said, what we're really going to track on now is not so much case rates, it's hospitalization rates, and secondarily, proportion of all people that are in the hospital that are due to COVID. And so their mask guidance changed, recommending the grid on the, or rather the table on the right, were new COVID admissions per 100,000 at 3 different cut points, less than 10 per 100,000. That's a 7-day total, not an average daily, but a 7-day total. Medium 10 to 19 and high greater than 20. And then percent of staffed beds occupied by COVID patients. Actually the same breakpoints or similar breakpoints, less than 10, 10 to 15% and greater than 15%. And then they further nuance it by saying if your case rates are less than 200, we play it one way. If they're more than 200, we play it a slightly different way. The table on the right really shows you what playing it a different way actually means. And the major implication is if you're in a low level, again, fewer than 200 cases per 100,000, fewer than 10 COVID admissions per 100,000 over a 7-day period, and less than 10%, really masks are not recommended at all in a general way. If you're in the medium zone, masks are recommended if you are at potential risk. And then finally, if you're in a high zone, masks are recommended in public indoor settings, including schools. Now that's not mandated. CDC doesn't make mandates, but it's recommendations. And I'll show you in just a second sort of what those maps look like when you play it by the old transmission rate system versus this new way of looking at severity, mostly measured by hospitalization. Next slide, please. And speaking of hospitalizations, this is what our hospitalization rate per 100,000 has been in our counties. This takes us all the way back to the beginning of 2020. So it's the entire pandemic squeezed into one massive slide. Thank you, Adam Anderson and team, for pulling this kind of stuff together. This is looking at hospitalization rates per 100,000 on a daily basis using a 14-day rolling average. Adam invented this way of monitoring things last spring when we had the extension of the dial. You guys may remember that. We actually shifted from case rates to hospitalization rates. I'm not sure the CDC knew we do that, but a lot of folks were saying that's a smarter way of doing business. At the bottom, what I've tried to do is translate our daily case rates into the CDC's 7-day, less than 10, 10 to 20, greater than 20. So low is greater than 1.42 cases or hospitalizations per day. Medium is 1.4 to 2.8, and high is greater than 2.8. And the red arrow sort of shows you where we were in the high zone until the end of January. And we got into that high zone somewhere around the middle of December. But if one reflects back on, at that point, CDC guidance was masked for everybody really since last summer. But you can see how that difference would be made in terms of that high level of recommendation, depending on these new criteria. And the slide on the right is simply showing you statewide new hospital admission data, once again mirroring pretty closely what's happened in our Tri-County region. Next slide, please. Two more snippets of hospitalization data on the right. Total number of patients currently hospitalized for COVID. This is actually what the state's been following more than anything because it drives hospital capacity. And we're now, from a state perspective, the lowest since September of 2020. So once again, not the most in the past year or the most in the past year and a half, but really you have to go back to 2020 to be as low as we were. The right graph shows you our best ways of following percentages of beds occupied by people with COVID. That's the other major CDC metric. And you can see that when we were in the middle of Omicron back in January, we were up to almost 30%. We're now down to about 5% or so. Remembering again, that CDC cut point was less than 10. So we're by both CDC criteria from a hospitalization perspective, well in the low zone. Next slide, please. These are the maps that I was referring to. This is how fast things are moving using these new CDC criteria. When the CDC put this data out, the map on the right on February 24th was how the country looked from a low, medium, high perspective. And as you can see, as rates have dropped, sorry, the graph on the map on the right is a little lower resolution. You don't see the counties quite as well. But you all know where Arapahoe County is, in Adams County, I'm sure. And you can see that the entire eastern part of Colorado is pretty much green, as is now the majority of the country. Again, no one is necessarily religiously following this in terms of masking. My guess is that masking is not very good in West Virginia right now, which is, as you can see, mostly orange. But it does give you some flavor about how the dynamics in terms of what that new set of recommendations would look like has evolved. Next slide, please. So moving to vaccinations, I think the main thing here, if you look at the histogram at the top, which takes us back again over a year now to looking at vaccine uptake, it really began to slow down in April. We hit our peak April of 21, kind of up and down a little bit in the summer, but at a very low level. It maybe went up ever so slightly in the beginning of December with Omicron, but not much. And it's just been flattening out since then. So that's observation number one. Observation number two is that when you look at rates across, particularly our current two counties in the district, but also Douglas County that we're still serving, the overall vaccination rate, the completed vaccination rate, where Adams County was actually lagging substantially behind the other two counties, and Arapahoe was lagging behind Douglas, have now really gotten very even. I mean, the overall rate is above 80, and it's within 2 percentage points across all three counties. The completed rate, that's a 2-dose or a J&J single dose, was also within 3 completion points. Where we do see a little bit more of a difference is in the booster rate, with Adams County about 8% lower than Douglas and about 5% lower than Arapahoe. The other point to be made here is that we've got this residual 18 to 20% of folks that have not chosen to be vaccinated. And we just don't seem to be budging very much for that. So as we continue to think about what it means to try to live with this as an endemic virus, I remain hopeful, although maybe naively hopeful, that with more and more information about the safety of the vaccine and more information, and frankly, maybe more normalization about how many people have received it, and God could only grant us less polarization and divisiveness as we get rid of some of the things that may have contributed to divisiveness, frankly, such as both vaccine and mask requirements. Maybe there will be more of a penetration of that remaining 20%, but it does remain, I'd say, in terms of moving beyond the pandemic, the major problem we still face. Next slide, please. This gives you some flavor of how the modeling team is looking at protection provided by the vaccination. This is looking at what I showed you a month ago versus the same 4 graphs 2 or 3 days ago. The one interesting thing here, I mean, the measure on the bottom 2 graphs on each side show that the higher your vaccination rate, the lower your hospitalization and death rates. Prevention of severe disease. That has been the calling card, the rock solid high value of vaccines. And if you look at the graphs a month ago and the graphs this month, the trend looks pretty similar. What's pretty interesting, if you look at the graph in the upper left, cases versus vaccination, that trend has reversed over the last month. We're not seeing as striking a correlation in prevention of cases. And I think what's going on there is really 2 things. One is that a lot of the places in which vaccination rates were lower had more people infected with Omicron and more natural immunity. And I think the natural immunity part of the equation, which I've always thought was going to be real, just hard to quantify how important, has really flattened the acquisition part of the equation out. But what it hasn't done is flattened out the protective value one sees from getting vaccination against both hospitalizations as well as death. Next slide, please. The other place we face challenges is differential vaccine uptake by ages. I've told you this before. And again, it's incrementally, but slowly incrementally getting better for our youth. Again, Alex and team are particularly mindful of our 5 to 11 and 12 to 15, our school age kids. In case you don't have kids in school, you may have forgotten school's going to be out in about 2.5 months. The next 2.5 months is our big window to work with our schools. They've been very eager to work with us. And except for that one little bump we talked about last month with the fraudulent event at Littleton High School, I think there is a lot of interest in the schools in promoting vaccinations as avidly as possible. Next slide, please. Tiny graphs, same graphs I showed you last time. We still have a problem with disparities by race, ethnicity. Some of this is likely due to incomplete ascertainment of race, ethnicity, but most of it's probably real. The Colorado Denver Gazette published a piece about this a couple of days ago. Colorado has got one of the worst disparity rates between white and Hispanic persons. This is a huge reason why Alex's team has really been, it's not new, we've known this, trying to employ some re-energized strategies around dealing with our Hispanic residents to try to reduce that rate. Frankly, I'm disappointed I haven't gotten more information from the state about which counties have lower disparity rates than our counties do. I asked for that about a month ago because I'd really like to figure out who's doing it better than we are. I don't think actually that many places are, but it remains a major conundrum as to why Colorado's rates are lower than rates in other states in the country. And I think it's an important issue, remains an important challenge for us to figure out. Next slide, please. And again, a sort of a quick summary about what Tri-County's equity-focused COVID efforts are dealing with right now. I'm going to mention just a second, undoubtedly you heard the governor announce his new roadmap to moving forward. This is going to, I think, promote a vision about how we move into a more endemic way of living with the virus. Unfortunately, however, some of the things that we've been relying on in our communities are going to get impacted. So the state-run ongoing or static vaccination sites, particularly those at Waterworld, Dick's Sporting Goods, the Aurora Municipal Center, Arapahoe Community College, Douglas County Fairgrounds, are going to close on March 31st. Now, I don't think their closing is unreasonable because the traffic at these places has dramatically dropped. But it does mean that we're going to have fewer sites. Testing sites are going to scale back as well. There are only going to be 7 across the state by June 30th. And one of the things I'm asking, I'm serving as a local public health representative on the state's policy committee, is as they are planning this pivot to endemic, is what it means to be sure we've got sufficient surge capacity, particularly for testing, but maybe also for vaccination should variants that require new types of vaccines come along. So again, this is an understandable development. These are expensive sites to run, but it will reduce some of the opportunities for our communities. We were able to start giving incentives on March 1st at some of our fixed vaccination site for primary doses, $100 Visa cards. Those have been helpful in the past. We've had many successes with partners in the Hispanic community, particularly church-based clinics, working with a new partner, who Lisa Soto, who called out Alex's team for partnership in that article in the Gazette that I mentioned a few minutes ago, as well as Mi Pueblo Market, as well as outreach partnership for Cultivando, the group that Kate mentioned regarding air quality monitoring. Our vaccine champions are a fantastic group. If you didn't get a chance to watch the video, watch it. It's like a video is worth 1,000 words in terms of the energy of the folks that Alex has got working with her. We are re-strategizing our work to close the vaccination gap in priority populations. We'll be completing our data collection process in April. And we are clearly hearing a continued request and a need for human-to-human sharing of information. In April, we'll be revising our work strategy based on those learnings and setting corresponding programmatic goals. Testing, as I think everybody knows, is undergoing, maybe not a revolution, but certainly a fairly rapid evolution to at-home antigen tests. We've been very active, involved in distributing home antigen tests. The CDC is placing with community partnerships. I want to really call out Chris Houck's work in working with partners to place these tests. Unfortunately, there's limited supply. We don't know how long that's going to go on. Unfortunately, we heard yesterday Congress is feeling a little less appetite for funding more COVID response efforts, which in a big part is going to include testing. We're keeping our eye carefully on that. We distributed, or that program distributed over 600,000 tests to various community organizations, municipalities, or fire departments during its first month. And Chris's team is working to add more partners. And then finally, we will continue our focus on creating opportunities for increased equity in all of our COVID recovery efforts. I'm very pleased to see that the state's plan does continue to pay attention to equity, even though equity remains an ongoing challenge. And Alex has called out specifically vaccination and testing. I will add that I've also asked our disease control team to sort of double down what role we can play in enhancing treatment. Treatment supplies were scarce as hen's teeth when Omicron was killing us. They're getting more plentiful now. There are new programs trying to expand treatment access in pharmacies. And we won't be the primary purveyors of that treatment, but I do think there's some dots that we can connect, as we've done, I think, really well in the testing and vaccination space. Next slide, please. And speaking of plans, again, Governor Polis's roadmap to moving forward, that was followed the next week by the President's National COVID Preparedness Plan. I want to specifically call out, I'm not going to go into what these plans outline. They've each got slightly different priorities in them. For example, the President's plan has got a bigger focus on global vaccination, which is obviously not relevant for Colorado. I do want to point out that we're already beginning to hear implementation information about the test to treat strategy. This is where pharmacies that are offering testing will also offer treatment. We're told that by the end of next week, we should be getting a list of which pharmacies will be taking part in that, and that program may be actually up and going by the end of the month. We've tried a lot of stuff during COVID, and we've been learning as we go. We'll sort of see how this works. But the big idea here is you want to try to link testing and treatment as tightly as possible. because there's a window of time. It's 5 days for the oral drugs and 10 days for the monoclonal antibody. And if people wait too long in their symptomatic course to access treatment, you've got a real gap. And I think this getting treatment connected to the place of testing is really a potentially very promising idea. Next slide, please. Other major news, it's actually a fairly big deal for our team, was updated guidance from CDC last week about revised guidance about case investigation and contact tracing. We've employed hundreds of incredibly dedicated people over the past 2 years helping us with case investigation and contact tracing. And CDC has no surprise to this, by the way, recommended as of last week that it's not universally recommended. The case investigation should be prioritized for populations at particularly high risk congregate settings, especially those with recent onset of symptoms. There's some revised guidance about outbreak investigation and a lot of encouragement to do what Michelle and Jen Chase and the team have been doing already, which using other strategies to enhance, meticulously calling everybody on the telephone to try to get the word out. We are attentive to what it's going to take to maintain this function while we really have more staff on serving with us now than we really have need, even with these new directions from CDC. Next slide, please. And Michelle and Jen and team have reviewed our current situation, reviewed the CDC guidance, strategized about where we can best put our efforts, outbreak investigation and identification, community support for those who need it to be in isolation, which is still recommended if you test positive, particularly focusing on priority populations such as the residential care and those in disproportionately impacted neighborhoods. Not something recommended by CDC, but certainly we think important from an equity perspective. Maintaining bilingual capacity. Not everybody that works for us speaks Spanish, but we do have good access to those who do. Again, getting more deeply involved in therapeutic connections and continuing community outreach, public communications, data and surveillance. Now, we currently employ 195 COVID-19 COVID staff, including 150 that work in the EPI program. Those are the people that do the CICT. And Michelle and Jen did a really careful review and decided that for the first time since the pandemic hit, we're probably ready to more right size the number of staff working with us. And we'll be having 40 of our CICT staff transition out of Tri-County. We're really looking hard at how we make optimal use of the other remaining 114 staff. I want to point out that this is a conundrum being faced across the state and the nation, which is what do we do to maintain surge capacity without having people sitting around? And I really do appreciate the team's effort to both rapidly scale up 2 years ago, that was unprecedented, and now begin to scale down, because that's also challenging and unprecedented. Next slide, please. And we're getting close to the end, looking ahead for the rest of the year. Again, I remain, continue to remain optimistic about what we're going to be seeing in the spring and the summer. I want to be cautious beyond it. We're going to continue to focus on our priority efforts for equity and diverse groups and vaccination for both boosters and older adults, as well as the kids. Continue to to remind our communities about how our public indoor spaces will remain important even with high rates of vaccination. We proactively plan what it means if things get worse again. We need to not forget that masks can be important. We need to be attentive to how to optimize ventilation in indoor spaces. We really do want to figure out our appropriate role in enhancing treatment as we shift to endemic accommodations and figure out what our options for surge capacity will be. And as we very, very happily get back to focusing on the other important public health issues and their impact on health equity. We remain very mindful of what we've talked about here before. There was a nice piece on Colorado Public Radio this morning about rebuilding trust in public health. I want to thank Becky O'Gwen and her team for trying to do some pushing the envelope, kind of thinking about what that trust rebuilding looks like. And then finally, I guess the last thing I want to say is that if we do wind down and we don't get another variant, God, what a blessing that would be. We can't not think about what we've been through, and we can't not think about what its implications are for the future. There were 2 studies published within the past week that, for example, documented pretty clearly. One study involved over 1 million kids in schools, that in school settings, mask requirements actually worked. They actually worked. And we didn't have the capacity to do those sophisticated studies in Colorado, and certainly not in Tri-County that control for vaccination rates and underlying risk factors, et cetera, et cetera. But a big team at the NIH who published the one study did, and another team at the CDC did as well. And I think we're probably, I would have loved to have had those studies last fall when we were being asked all the questions we were. But I think it's going to be important for us to be attentive to new information as it gets collected and synthesized, whether it's for a new variant in the future or whether or not it's for another respiratory virus outbreak that is certainly theoretically possible in the future. Last slide, I think, Lisa. I don't know that we want to take a lot of time for discussion because I know we want to move into our next part, but I want to echo what Kaya began the meeting with, to say, yeah, it's been about 2 years. What a hell of a 2 years it's been. And I want to really bookmark the appreciation, not only to Tri-County staff, who, as far as I'm concerned, are the best in the world, but also our Board of Health. I've privately thanked them, but they deserve to be publicly thanked along with our staff, because they've been through every bit as much of the storm and drama and craziness of the past 2 years as public health, hospital workers, et cetera, have. And I certainly don't want to leave out our way too many to count community partners. It often felt divisive, but underneath the divisiveness, it was rock solid collaboration by so many folks in the community, without whose support none of the improvements that we've seen could have happened. So just a final note of deep, deep appreciation to all of the above from me. And happy to stop now and take any questions. Dr. Faywell.
Thank you, John. That was a very good presentation. Just 2 things. Since Europe, Denmark, Germany, UK, seem to be a month, 2 months ahead of us with regard to variants. The BA2, you said, was 50% of the cases in Germany. Does that have any correlation with hospitalizations?
Tom, right now it does not. The Danes were experiencing about a 50 to 60% rate about a month ago, at the same time that they were dropping most of their restrictions. The Germans, as I just said, are experiencing a record number at the same time as they are dropping the restrictions, and they are not seeing a surge in hospitalizations. So those are just 2 countries, but they're reasonably sized countries with good surveillance. So I would take that to be a sign that if BA2 does get higher, it's likely to get higher in a non-severe infection-producing kind of way.
Yeah, let's hope so. The other thing you partially answered, we keep talking about the non-vaccinated 20%. Does the vaccination champion team ask the people who are not vaccinated whether or not they have had COVID, whether they recovered from it, so that we would then have a thumbnail sketch on how many have been vaccinated, how many have recovered, and then you've got that percentage that haven't been vaccinated and haven't had the disease that are at more risk?
Yeah, a really good question. I'm going to let Alex answer. My guess is they don't do interviews so much as just exhortation and encouragement. I will say that I've talked to the state epidemiologist about whether we could combine CIS data where the immunizations are recorded and CEDARS data where the cases are recorded, to see if we can get the kind of cross match you're talking about. Who in CEDARS has been vaccinated, who's not been. Those have all been infected. That's how they get into CEDARS. And could we create a sort of a a hierarchy, even really a distribution across the state of what that looks like. Now, remembering that Cedars is an underestimate of cases because not everybody gets tested, and especially in the world of at-home antigen testing, it's not going to all get reported. I don't think we have that information at our community interaction level, although I would love to have it. Alex, anything to add about our champions? I'm guessing we haven't asked them to dig into that kind of thing, or is Alex still with us?
Yeah, Alex had to jump off, but I don't believe we go into that depth. That may come up in conversation, but we're not documented. Dr. Powell into asking that as a specific type of survey question, but not specifically. But yeah, it's more of that answering questions and getting information.
Thank you.
Thank
Great
you.
job, John.
Jan, did you have a question?
Go ahead, Kaya, you had your hand up before me.
Okay, thank you. I'm just curious, I've seen the modeling that suggests that a lot of people have immunity, either because they've been vaccinated or because they've had COVID. And I'm just wondering, given that there are so many more people now that can do at-home testing, can we know whether the virus is still circulating in an asymptomatic format? And is that really not going to be a problem unless people start to get sick again?
Well, there is still testing going on, but we don't really have a good, I mean, Chris Houck monitors the testing really carefully, and it's certainly dropped off since the Omicron peak, and it did trend with it. So we do think that people actively seeking PCR testing have, at least thus far, been a pretty consistent with the trends overall. But I do think rapid at-home antigen testing, for very obvious reasons, is likely to supplant it. And then your next question comes in. Yes, I do think hospitalizations will end up being, not only because they represent the more severe end of the spectrum, but they represent the more reliably collected part of the spectrum. If you're sick enough to hospitalize and be documented to have COVID, that's going to get reported. It may be a little delayed, but that's going to get reported.
Thank you. Jan?
Thanks. I was just curious. I know some folks that came back from Mexico last week. They had symptoms. They got tested. They were positive. They report it to no one, so those aren't counted. And that was a business trip with a bunch of people from the company. But when they called me, I said, well, how many days have you been? Maybe you should talk to your doc about some of these pharmaceuticals. They weren't interested in the pharmaceuticals. So I don't know. And I don't know, they did talk to their doctor, but I don't know if they were beyond that or if the doctor even mentioned it to them. But I'm wondering, are we educating the physicians to use them? I get the hesitancy because you're not hearing a whole lot about them. And just like in the beginning, everybody was afraid of the new new vaccine that was so different. And so I'm wondering if people are hesitant about taking these drugs as well.
That's a really good question. We are, Jan, I would have to say we're not doing massive physician education. We certainly distribute the health alerts through Michelle's team that come out that have a lot of updated information about therapeutics. The state is trying to launch broader campaigns, particularly around a topic I meant to mention and forgot to, called Evusheld. It's a monoclonal antibody injection for immunosuppressed people who either aren't likely to have responded to the vaccine or have a reason not to have gotten vaccinated. I think that's going to be an important issue. I know the Colorado Medical Society is interested in educating its providers about it. I think part of the problem, really, even now, but up until quite recently, has been there's been such limited drug, especially drug that the average doc can prescribe, that I think there's been, I mean, honestly, if I was one of those docs, I probably wouldn't have spent the time learning about it, because I would, when it's around, I'll learn about it. I'm hoping we could do a much better job educating docs around these meds than we have, for example, around Tamiflu for influenza, where, it's actually not nearly as good as these drugs, but we've had pretty low success with docs prescribing in indicated circumstances. What I'm really interested in is, especially when we encounter folks that may be high risk, is that one of our, I mean, yes, we want to try to instruct them to isolate. Yes, we want to try to instruct them to talk to their partners or their contacts, but we absolutely want to at least give them the ABCs of treatment. We're not going to be doing medical triage, don't get me wrong, but we could at least identify people who ought to go seek out more information about treatment.
Okay, thanks.
Julie Shields?
John, I'm wondering if it's a perspective question as we start to discuss endemic. I'm curious if you think that there's enough tracking of those who are experiencing symptoms of long COVID and how that might be impactful as well.
I think long COVID is a huge part of the iceberg that's been really poorly understood. That's actually a pretty high priority in the president's national plan. It's not a named priority in our plan, but I think we've never had good surveillance systems for this, Julie. And, you know, it's a constellation of one or more of 200 symptoms. So it's all over the place. It's been hard to create a case definition, but I think we definitely need some sort of sentinel surveillance systems. Those have been talked about. I think they're being used in some places to try to get an idea about fractions. I honestly, I haven't thought a lot about what other surveillance systems about long COVID could look like, but I think it's a really topic of emerging importance. There's a lot of discussion now about long COVID and disability and folks being recognized as being eligible for that. So we're, in contrast to the pandemic of 1918 and 1919 and pan flu, which killed so many people, there was not anything like this persistent sequelae. And I think that'll be a really important dimension for us to be recognizing and hopefully dealing with more effectively in the future.
Thank you.
And I think it deserves much better attention from a data perspective. Let me just say that again than we've given it so far.
Thank you. Not seeing any more questions. We'll move on to the executive director's report. Any comments or questions about the executive director's report? I'll just say, after my congratulations to Dr. Douglas and Burnett Albanese, who were recognized in Congressional Record for their leadership related to the public health response for COVID. So congratulations, great job as usual. Lots of other good, important information in the executive director's report. Jan, did you have a comment?
I did add a question and a comment. First, I'd just like to say, in the vein that you were speaking of, congrats to Emma Goforth and Heather Baumgartner and their team. They had such a large and diverse group that they convened for this mental health and suicide summit. And what struck me most, and granted, I'm not the most experienced in this, but they had an incredible actionable movement for a first meeting of a summit. And they have got the wheels are really turning and really fast. And I think it's a testament to the leadership of the people in Tri-County, especially that team. And the other, so thank you. The other thing I had was for Dr. Douglas, when is the ICE detention, I know it's is it in Adams or Arapahoe County, the ICE detention facility?
It's actually, I haven't been there in a while. I'm almost sure it's just north of the county line in Adams County.
Okay.
Jennifer's nodding. So if Jennifer's nodding, it must be true.
So I'm thinking ahead to which county is going to inherit that and the things that go along with it, such as outbreaks of COVID, outbreaks of food poisoning, and everything that Tri-County has been investigating. And I was just wondering where that would fall in the future.
Yeah, and I'm actually quite sure it's in Commissioner Penner's district, because she was involved with some of the stuff of the mumps outbreak. So it is an Adams County facility.
Oh, okay, thank you.
If I could call attention, I know the board's already read all the material, you read it and digest it. I just want to highlight, really appreciate MAME trying to help us track on what's happening with our staffing challenges. We continue to have them. Our executive management team has been nothing short of extraordinary in trying to help us figure out how we deal and support our staff during this challenging time of ambiguity. Really do appreciate their efforts in that regard. And I want to thank Jennifer and Adam and Jill and Monique for their role in making very, very tough decisions about 3 entities that we decided a couple of weeks ago we probably needed to put on pause. Those being our reaccreditation effort, our new financial system, and maybe in some ways most heartbreaking because it's been so fantastic, award-winning is our dietetic internship. And none of those have gone away entirely. And we really are maybe are most hopeful that we can find a home for the dietetic internship because it's been such a major contributor to registered dietitians getting a solid public health grounding. But I did want to call those out in particular.
Great. Thank you. Just run through the last couple of items here. In terms of setting the agenda for the upcoming board meeting, we are scheduled to approve the year-end financial statements. We'll have a follow-up on mental health and, as usual, an update on COVID. If there are any other topics, be sure and let Julie, Mullica, or myself know. In the meantime, are there any suggestions people would like to make at this point in terms of things you would like to see on the April agenda? Yes, Rosanna.
If at all possible, I would like to have the any legal executive sessions at the beginning of the meeting rather than at the end.
Okay.
If at all possible.
We'll take that into consideration. Thank you. Are there any other board member remarks people would like to make before we? Yes, Dr. Faywell.
Question probably for Jennifer. The much anticipated report that'll come out at the end of this month, how will that be communicated? Are we going to have a special meeting, a Zoom, what?
Can you clarify what report you're referring to?
The consultants report, Towie and the committee that's been working on planning going forward. We have 9 months before we need a health department in all 3 counties. And this report that's supposed to come out at the end of the month is going to be this great revelation. I'd like to know how we're going to hear about it.
Sure. So actually, I'll clarify. So Ottawa, in working with Arapahoe County, has a totally separate scope of work and contract with Arapahoe County. So they are, they're working with us, but their contract with Arapahoe County, helping them in building their plan, is a separate scope of work and a separate, it's a contract with Arapahoe County, not us. I do not believe, Ottawa is not an expectation of their scope of work is not to present a formal report to us or to Arapahoe County, even my understanding. I believe they're just working with the staff team, their internal transition team, on recommendations that then go to the Board of Health, the Board of County Commissioners. We understand that there is a town hall for Arapahoe County residents, constituents, on the 30th of March, where we anticipate probably them sharing updates on how they intend to proceed moving forward. And actually, I thought I saw Commissioner Jackson is on, and I don't know, Commissioner Jackson, if you want to add any more, but I don't believe that Ottawa is intending to create as a work product, a report. And if they did, it would belong to Arapahoe County. We, as part of our executive session tonight, can talk through additional meetings and updates that you would like to have as a Board of Health so that you are well informed of the plan moving forward.
And I can just add that Jennifer is 100% correct. There is no plan for a report. We are going to be discussing some recommendations at the end of March, and then we'll have our town hall on, I think it's March 30th, where we'll take questions and so on. I can't remember whether our study session, which is an open study session, where we will be discussing these recommendations. I'm not sure, I can't remember if it was the 28th or the 29th. It looks like it might be the 29th. Yes, it'll be the 29th, around 9:30 or so. Yeah, no report, just some recommendations. We're working, we go to lots of meetings there. We're working with Tri-County Health, we're working with the Ottawa group, and we're trying to figure this out.
Thank you.
Thank you. Rosanna?
Hi, I just like to pass on that it was shared with me that many folks in the North Aurora, Adams County side got a mailing about a survey of what they thought was important for a health department in Arapahoe County. So that's what it is. They lived on the Adams side of Aurora.
So what you're saying is people who were living in Adams County got a survey asking about Arapahoe County?
Yes, those that live on the Adams County side, north of Colfax of Aurora. It's on the Adams County side, but they got a mailer about what do you think, what do you want, services do you want for a new health department in Arapahoe County?
Okay.
I'm just passing it on to Commissioner Jackson.
Commissioner Jackson, great, thank you. Yeah, I can see that our legal team is ready for the executive session, but I'm going to use my prerogative to ask if we can revisit the vote on the bylaws, because when we took the vote earlier, Rosanna and Julie Mullica were not with us. And so as you may know, if you look through the packet, the amended bylaws that we are voting on only change some of the language to reflect what we've already decided on, that there would be 2 co-chairs. And so it was just correcting some of the language to reflect that that's the way we're operating right now. And I guess I would just like to see if anybody would like to make a motion to approve those bylaw changes at this point.
Move to approve.
Is there a second?
I'll second. This is Julie.
Julie, great. And Dr. Fay was already expressed the fact that he didn't agree with this before and doesn't now. Is there, if you would like to have any other comments, Dr. Faywell, or is there anybody else would like to say anything at this point?
No.
Not saying anything. Can we take a vote to how many people would agree with the amended changes? If you do agree, say aye.
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 Is there anybody opposed?
Nay.
Dr. Faywell, thank you. So Ronnie, it looks like by my count, 5 people agreed to it and 1 person disagreed. Great. Before we leave, I just want to thank again the Board of Health members for your ongoing commitment in terms of your time and your interest to protect the health of our communities. Thank you again for your fabulous contributions. And at this point, we will move into our executive session. And I believe Dr. Sid, could you give us the language that the provision that allows for the client attorney consultation with the Board of Health? I think you're muted, Sid.
Yeah, good evening, Madam Chairman and board members. As we move into executive session under the attorney-client privilege portion, this would be under Colorado Revised Statutes, Section 24-6-402, parentheses 3, close the parentheses, parentheses A, close the parentheses, and we can proceed. And it's my opinion that there will be no necessity to record the minutes or keep minutes of this meeting.
Great, thank you. Do I have a motion to move into executive session?
So moved.
Is there a second?
Second.
All in favor?
Aye.
Anyone opposed? Great, thank you. Renee, could you move us into executive session, please?
I will, but first we need to state the purpose of the executive session. We need to state the topics that are going to be discussed.
Thank you for reminding me that. This is a session for consultation with our legal counsel.
Right, but you have to state which topics are being discussed in accordance with Colorado Revised Statute 24-6-402. That's my understanding.
Okay, great. We're going to have an update from the Brownstein team. We're going to have a report from Sid Overton and Randy Demmett, and we're going to be talking about possible next transition steps. Is that correct, legal team?
Yeah, I think that's essentially what we're covering tonight.
Okay, great, thanks. Well, it looks like we have a motion to move into executive session, so we will see you in the next room. Okay, let's see. 1, 2, 3, 4. We've got all the board members here. We've got our legal team.
We still have 4 attendees. So if you're an attendee at the Board of Health meeting, I'd like to respectfully request that you leave the meeting at this time so that the board can move into executive session.
Could you let me know? Oh, it looks like we're all clear. Great.
Are we? I don't mean to interrupt, but I do see on my screen it says live on YouTube. I don't know if that's just on my screen.
Yes, let me go ahead and discontinue the live stream. Then I'll go ahead and lock the webinar, and at that point we can have our conversation.
Great, thank you.